As we celebrate Valentine's Month, have you ever wondered how serious a broken heart can be? Stay tuned for Health Watch. Hello, I'm Terrence Anderson, and this is Health Watch. I'm wearing my favorite red tie and suit today because during the month of February, the American Heart Association celebrates National Heart Month. Of course, it is also Gold Red for Women Month, recognizing women and heart disease. Did you know that heart disease is the #1 cause of death of American women? But let me ask you something. Have you ever heard of anyone dying from a broken heart? Is it really possible? Well, you might be surprised to know that there is a genuine medical condition known as broken heart syndrome. The clinical term is stress-induced cardiomyopathy, or Takotsubo cardiomyopathy. In case you're wondering, a Takotsubo is a Japanese-designed pot-shaped octopus trap. It closely resembles the shape of a human heart when it is in grave distress. But when someone suffers a classic broken heart, having been emotionally stricken by the loss of someone dear, it can actually impact the health of their human heart. There are clear links between depression, mental health, and heart disease. The American Heart Association tells us that women are more likely than men to experience the sudden, intense chest pain associated with an emotionally stressful event. It could be the death of a loved one, a divorce, a breakup, or a physical separation, betrayal, or even romantic rejection. Yet it doesn't have to be a disheartening event. It could even happen after an incredible and unprecedented positive experience, such as winning the lottery. In those instances, the chest pain that is experienced is a reaction to a great surge of stress hormones. The American Heart Association tells us that broken heart syndrome can also be misdiagnosed as a heart attack. This is because the symptoms and test results are so very similar. A broken heart syndrome can yield dramatic changes in heart rhythm, as well as the blood markers typically evident in a heart attack. However, unlike a heart attack, there's no evidence of blocked arteries. In broken heart syndrome, a part of your heart temporarily enlarges and doesn't pump well, while the rest of your heart functions normally or perhaps with even more forceful contractions. So today on Health Watch, we're going to have heartfelt discussion on affairs of the heart, more specifically, the health affairs of the heart. And to help us navigate through this discussion, I brought on board the most knowledgeable cardiologist I know, Dr. Keith Newby, President and founder of Fort Norfolk Plaza Medical Associates. A native of Hampton Roads, Dr. Newby received a Bachelor of Science in Biology from Norfolk State University and later earned a Doctor of Medicine degree from the Eastern Virginia Medical School. He completed an internship and residency at the Emory University School of Medicine and completed a fellowship in clinical training in cardiology with emphasis in invasive electrophysiology at Duke University Medical Center. Dr. Newby is board certified in cardiovascular disease and cardiac electrophysiology. But what I also personally find most impressive about Dr. Newby is that he is very active in the community. For example, he is currently working on a foundation that will educate local residents on how to increase their lifespans while strengthening families by educating communities and providing them with the tools they need to decrease both the effects and the onset of cardiovascular disease. It gives me great pleasure to introduce Dr. Keith Newby. Welcome to Health Watch.
Welcome. Thank you very much.
This is the second time you've been on the show.
Yeah, I always enjoy coming back and seeing you.
And I'm glad that we have the entire show with just yourself, sir.
Yeah, well, thank you very much.
We're going to talk about broken heart syndrome and generally cardiac health. But I'm very, very impressed with your facility, the Fort Norfolk Plaza Medical Center. And it's a fairly new facility, so if you could tell us a little bit about the facility, where you're located, and contact information and all of that.
Well, briefly, the facility was developed really back in 2006. I put together some ideas of creating this all-in-one inclusive facility. Of course, you know, that was 2008 was when we actually got the loan approvals right during that time of the stock market crash. It was a little interesting trying to get financing during that time, but through a lot of diligence and perseverance, we were able to achieve that goal. So it's really a 200,000 square foot facility. It's actually right across from Norfolk General Hospital adjacent to the public health building, which is one of your facilities. And it's on Riverview Avenue. So it's 301 Riverview Avenue, Suite 500. Is where we're located, but our contact number is, of course, 757-624-1785.
You know what I really like about, well, we park, of course, in your building, but I recently directed a show on the peninsula, and I live in Portsmouth now. And whenever I was coming back home, I'd take 164. And I'm not sure if you're aware of this, but at night, you can look across the harbor and see your building all lit up, and man, it stands out. It's beautiful. It's absolutely beautiful.
We had a very good architect, Willard Cooper, as turned to be a good friend of mine. We kind of went through that process of trying to get that building up, and he actually designed all that to bring that out at night. So it was a good, nice touch.
Great lighting.
Well,
absolutely.
Thank you.
Now, I talked about broken heart syndrome earlier. And of course, there's a heart attack. Can you tell us a little bit more about the difference between the two?
Yeah, essentially, when you talk about a heart attack, you're talking about a true occlusion of blood flow through arteries that supply blood flow to the heart muscle itself. And look at, any other muscle, it requires oxygen in order to function. And the heart, although it is a pump that pumps blood to the other muscles to function, it needs its own blood supply as well. And that's achieved through the coronary arteries. So when you have an obstruction of blood flow to a coronary artery, that's where a heart attack occurs, and that has to be a total obstruction. Talk about broken heart syndrome, and I actually have personal experience with this, as I've had several patients who've actually had that, where you will find that there is no true obstruction. They'll have all the signs. They'll have the EKG changes, you'll see symptoms, and you actually have had times where you test the blood and you'll get these rises in enzymes called troponin levels, which is really what we use to diagnose heart attacks, and they will all be up. But when we do diagnostic catheterizations and look at the arteries, they're totally clear. And you actually will see wall motion problems where there's areas of the heart that don't function well compared to the other areas where you knew something happened, but it just wasn't any true obstruction that caused that to occur.
Amazing.
Oh, I tell you, I mean, it's really the upswing of it all is that when you have somebody like that, their longevity, as long as you get them, and you almost treat them almost the same as if you would a heart attack from blood thinners and medicines called beta blockers and other things. We normally do oxygen, sometimes morphine. We treat them all the same, and their outcome is excellent. As long as you get them early and you get people treated appropriately, this is like any other entity. The biggest problem we run into is getting people to come to the hospital to get assessed. They'll think it's gas or think it's something else, and sometimes they can die at home from that.
From broken heart syndrome.
From broken heart syndrome.
You mentioned EKG. Is there any difference at all, or are they?
Well, you'll find variables, but even in say a obstructive heart attack, you may not always see the classic EKG changes suggestive of such, meaning there are different types of heart attacks. You have your ST elevation, which means when you look at the EKG, you'll see classic findings. And then you have something called a non-ST elevation heart attack. And the ST segment is just part of the EKG tracing.
I see.
So if that, and you'll find some heart attacks that won't have the ST segment elevations. So the EKG is a good diagnostic tool, but I tell you, even during this testing environment where we've gotten away from the basics of medicine, which is your clinical acumen, I still say that's the best. You have to take everything into context. As example, you have, say, a 20-year-old young woman that comes in with symptoms of chest pain. I mean, characteristically, the likelihood of her having an ST elevation myocardial infarction is low. I mean, it's not to say it's impossible. It's just low. Take on the other side, a 65-year-old woman who smokes and has multiple other risk factors, and I'm sure we'll talk about that as we go along. You're going to look at that person with a more careful eye because there's a higher likelihood that they actually are going to have heart disease. So it's all about the diagnostic acumen or your ability to look at a patient and say, okay, what's the likelihood that this person has disease? And then you go after it. We take everybody seriously. I'm a firm believer in every patient that hits the emergency room door that I'm privy to see is going to get treated the same, because you never know until you know. But what we have to look at is likelihood, and that's the part I'm talking about more statistically. What's the likelihood this person has disease? Because you don't want to do heart catheterizations on everybody, because there are some intrinsic risks to that. So you want to make sure you carefully select those people when you're trying to figure out what's the best modality to figure out what's going on with the patient.
You mentioned the treatment and the beta blockers and so forth. So this, makes an ideal time to talk about that. And I want to concentrate more on what one typically expects of cardiovascular disease and heart attack and so forth. But last question about broken heart syndrome. So there is a difference in the treatment modality.
To a certain degree.
Okay.
The only real difference is the ultimate treatment if you need to open a vessel, meaning, say somebody's having a heart attack. Well, that typically means that the vessel is closed. So we'll oftentimes take these people to the heart catheterization labs. We'll do a diagnostic heart catheterization, and we'll inject dye material, look at the vessels, and see, do they have blockages? If they do, we would typically use balloon type technology with stenting, and we'll open the vessel up to get more flow to that area of the heart. Or in a situation somebody may need bypass surgery emergently, we will then send them to the operating room where the cardiac surgeons will operate and do bypass surgery. But with broken heart syndrome, they don't have those blockages. All the pre-treatment is the same, meaning you get them in, you're going to give them aspirin, you're going to give them beta blockers, you're going to give them oxygen. You're going to use morphine if needed be, because that does relax the patient and does relax the coronary arteries.
Beyond just the pain.
Beyond just the pain. Okay. It does have vasodilatory responses. So all these things are beneficial to the patient. So you treat, and then blood thinners, of course. So you treat everybody pre the final diagnosis the same. It's just what happens after that. Do they go to the heart catheterization lab? Do you find blockage, or do you find that really there's nothing there? And in those situations, and I think a lot of the problem is there is a noted increased stress hormone levels, or that you'll see in broken heart syndrome. The norepinephrine levels are elevated, and those are catecholamines that the body normally makes, but in stressful situations they can increase 2 or 3 or 4-fold, and they cause vasoconstriction. So if you get a scenario where you'll get an artery that constricts down, if it constricts down, the flow is not getting down to that artery into that area of the muscle of the heart that's trying to supply. So you'll have people who have this broken heart syndrome that they will get obstruction of flow temporarily, but that's because of vasospasm, and then the vessel relaxes, more flow goes back to the area of the heart, which could account for why that area of the heart does not move or function compared to the other parts of the heart. But once you reestablish blood flow, it's almost like the heart becomes stunned for a while. Just like anything else, if I put a blood pressure cuff on your arm and I pump it up, your arm eventually is going to start to hurt. Why does it hurt? Because I'm cutting off blood flow to that area of the heart. If I were to pump it up and just leave it there for 5 minutes and then release the air, before you end up hitting me for leaving it up so long, you will probably notice that it's going to take a while for the numbness to go away in your arm. It'll eventually go away, but it'll take a while. But that's because you cut off blood flow for a defined amount of time.
Recirculate.
You have to recirculate.
And that is the instance where, in some instances, you might use a balloon. Not necessarily.
Yeah, in the broken heart, typically not. By the time you get them to the lab, you'll inject dye, you won't see any blockages at all. A lot of times the vessels are relaxed by that time. And that's all theoretical. We've never actually, I've seen coronary spasm before, but not in the face of the broken heart syndrome, because characteristically, the way we handle these heart issues, the first step is always stabilization as best you can. So you want to get people on all the right medications, because look at it as an example. If they have a heart attack, that means they have clot in their heart. That area is unstable because of the lack of blood flow, and that's when you start getting heart rhythm disturbances and other things that can eventually lead to sudden death. So you want to try to alleviate that stress level, and with that those increased hormone levels and catecholamine levels, those things also can lead to heart rhythm disturbances. So drugs like beta blockers are used to decrease that stimulating effect that those catecholamines give. So beta blockers help to slow the heart rate down, and it takes away that extra stress. Aspirin is a drug, it's an antiplatelet drug, so it keeps platelets from clumping together. So you have, and we'll typically use things like heparin, which is another type of IV blood thinner.
Right.
All those are designed to stabilize the situation, decrease clot burden, and hopefully decrease the response that the heart has to those increased catecholamines.
Right.
So, you know, the treatment strategies are typically the same between the two. It's just by the time you get them to the lab, you've already pre-treated what typically the broken heart syndrome theoretically has done, meaning the increased catecholamines, the stress levels. You've given these people morphine, so that takes away their whole concern about whatever they came in there for a while. You've got the beta blockers on board that decrease the catecholamine drive. You take away any vasospasm or any decreased blood flow. You've already given them aspirin. You've already given them heparin, probably. So you've taken away all the things that they came in with in the first place. So by the time you get them to the lab and you try to take a look at those arteries, they've already relaxed, everything's back to normal. But you may see a residual, like that ballooning entity we talked about earlier. That comes from a result typically of probably, and again, this is all theoretical, spasm in the vessel supplying that area of the heart. So what happens is, because that area becomes stunned, the rest of the heart is trying to compensate for the fact that that area is not working well anymore. So it could get vigorous, the rest of the heart, where that area is not. So it kind of looks like a ballooning effect, because the rest of the heart squeezes while that area doesn't move that well. So it kind of looks like it balloons out.
And that could cause a general spasm.
Yeah, and that well, it could be as a result of that spasm. And then that subsequently can cause some of these other entities. The keyest issue is you want to reduce the risk of sudden death, meaning you know, what causes that, and what a lot of people get the term sudden death and heart attack confused. They'll use them interchangeably, but they're really not related. But sudden death can come as a result of a heart attack.
Certainly.
Sudden death just means that the heart rhythm, it went to a heart rhythm that's not sustainable with life. I don't know if you've ever heard the term ventricular tachycardia or ventricular fibrillation. Those are rhythms that oftentimes will lead to sudden death, because the ventricle or the bottom chamber of the heart can no longer pump effectively to protrude blood or to exclude blood or to get it out of the heart. So what happens as a result of this kind of rhythm disturbance is the heart ceases to function. So if it ceases to function, you can't live if it's not functioning appropriately, because no part of the body is getting adequate oxygenated blood. Brain's not getting it, the rest of the vital organs is not getting it, and what happens is everything shuts down. So if you have a scenario where, say, you cut off blood flow to the heart, even temporarily, if you don't get the right medicines on board fast enough, you can have a heart rhythm problem that can lead to a sudden death event. And so the key, that's why we always recommend people get into the hospital as quickly as they can. Because oftentimes if you get a person there quickly enough, you can prevent, or you can give medications that would prevent that entity to happen that would lead to sudden death.
So that we can let our viewers know what those instances where they do need to get to the hospital right away. I'd like to talk about the symptoms and signs, but before we even get there, if we could address more generally cardiovascular disease and risk factors for cardiovascular disease.
All right. If you look at most of the major risk factors, they're actually pretty common processes, things like hypertension or high blood pressure. And they're used interchangeably, and I can go into that in a minute if you'd like me to. Diabetes, elevated cholesterol levels, people that smoke, those that have a family history of heart problems. And when I say family history, a lot of people don't understand that what deems a family history is premature heart disease, meaning mother, brother, father, father, sister, a first-degree relative who has a heart attack or some coronary disease event at the age less than 55. That's what deems a family history. Once you're getting past in the 55, 60-year-old age range, anybody can have a heart attack. The potential risk goes up just on the age-related phenomena alone. That doesn't deem a family history of a genetic predisposition. That just means that, you know, say like if your brother had a heart attack and he was 65, well, he's got risk like anybody else to have that heart attack.
Right.
That doesn't put you at higher risk because he did, not at that age. Now, if he had it at 45, different story. That could mean that you have a genetic predisposition.
Understood.
So those are typically the major ones. You talk about some of the other ones. They actually just recently added obesity or physical inactivity as another risk. And unfortunately, so that is a problem we have in this country, where because of technology, you know, of course, everybody has a finger on the remote control, and people no longer get up and do things. You think about when we were kids. You know, your mother, you go outside, your mother sends you out, and you came back when the street lights came on. You knew that was the time to come back home. Now,
I'm much older than you are. But I do remember those times.
Well, you know,
but for me, it was just, you know, folks were rolling rocks around.
And that was those are times when you think about those were very much active days.
Indeed.
For you. Nowadays, it's gotten to where, you know, kids are on video games, and they're on iPads.
Right.
I mean, iPads are fun and they're great. It's just unfortunate, so they don't always, you know, give you that type of activity that keeps you healthy. So you'll see a lot of. That's why I think the childhood obesity problem has gotten so large now, because of that physical inactivity. You know, you got kids now that can't even do 2 pull-ups. You know, I mean, it's really a change in pace of what used to be the case.
Perhaps one day someone will invent a video game that demands interaction, you know, that also demands physical activity.
Yeah.
Let's talk now about those warning signs that you know, that someone need be aware of in terms of a cardiac event.
Well, I think if you look at most of the classic signs, you know, chest discomfort, and I really emphasize the term discomfort, because I've had patients who would tell me that they don't feel pain, but they feel pressure or tightness or discomfort in the chest. Characteristically, it's mid-sternal, meaning mid-chest.
Right.
It could radiate into the jaw, into the arm. It could radiate through to the back. Some people have no radiation at all. Shortness of breath. Now, all this stuff is acute, meaning, you know, I don't want people to think that every time they feel the least little thing in their chest, they need to run to the emergency room. People know when there's something serious going on. It doesn't take much for them to figure out that they're having a major problem. The standard, you know, you get a twinge here, a twinge there. I'm not talking about those scenarios. Prolonged, ongoing discomfort is what I'm referring to. Anything that lasts to me more than 10 or 15 minutes may require immediate attention. Some people will break out in a cold sweat, you know, where they just start pouring sweat. Some people will develop nausea, you know, and a lot of people think it's just gas that they had. It's just, you know, I think what I usually tell patients to kind of help them in terms of trying to decipher should they come to the emergency room. I always say, whenever in doubt, just go. But one of the things that, you know, I tell people all the time, I mean, if you're, and I mentioned this person is 20 years old, I mean, what's the likelihood of a 20-year-old having a heart attack? It's small. Right. It's not impossible, it's just small compared to a 65-year-old. But if you have other risk factors, say if you know you smoke like a chimney, I mean, you're a 3-pack-a-day smoker, you have high blood pressure that's never been controlled, you're diabetic, you have a cholesterol that's 300, you know, and your father died of a heart attack at age 32, and you start having chest pain, I mean, to me, there's no question that you need to be checked out immediately. Now, versus, again, a 20-year-old with no other medical problems, the likelihood is less. I mean, again, when in doubt, just go and be checked out.
We only have like about 2.5 to 3 minutes left here. Tell me about the State Health Elevation Conference.
One of the things that we're doing with the James E. Newby Jr. Foundation, my father, who is
I remember your dad well.
Oh, you sure you?
I remember, yeah. I keep telling you, man. You know, my father used to go to your dad.
Oh, okay.
Yeah, I remember your dad very well.
Well,
I liked him a lot.
Well, thank you. Well, he was an internist here in the area. Died very young at age 41. He had a primary heart tumor. I created a foundation in his name more to foster some of these clinical activities that we want to do, because educating the community into trying to get people to understand what needs to be done in order to live healthy, we want to be able to foster that. So this State Health Elevation Conference is a one-day conference. It's March the 2nd. And this year, it's going to be at 7:45 a.m. to 4:30 p.m. on Saturday, March 2nd at Norfolk State University.
State.
Is at the Student Union building. I've got a lot of my doctor colleagues together. We're all volunteering our time to do this. I reached out to business people, to finance people, and actually some of my church members to put on different lectures on different topics.
And how can someone find where?
Well, you can call our offices 757-624-1785.
Okay.
And we also have we have online registration. You can see the program and everything. It's www.vahealthconference.com. And that will give you all the information. You can register online. You can pick whatever lectures you may like to hear about.
Right.
And we're really touching on multiple topics, not just pure health, but finance.
Okay, now that is a web address I didn't have.
www.vahealthconference.com.
Okay.
And we just got that just recently because we wanted to have the online registration.
Understood.
Now, my Facebook page also has a noted area.
We do have that Facebook.
Yeah, and so we're hitting it from all angles. So we're going to be doing some other things as well.
Is there any way that I can help, Keith? Let me know.
Well, you can show up.
Yeah, well, absolutely.
That'd be great.
Well, thank you so very much for coming on to the show.
Well,
man,
quite welcome.
It's very, very good to have you back on, and we need to do this again.
I look forward to it. Don't be a stranger calling me back.
Well, I don't want to, absolutely not. And I don't want, I have that, the African American Men's Health Symposium.
Yeah, and that which I participated with.
Yes.
That'd be more. And I saw your email go out about that, so I figured I would be getting a call about that from you sooner or later.
Pretty soon.
Look forward to it.
Well, thank you so very much.
Anytime.
Nice to hear you.
You as well.
And we want to thank you for joining us for this edition of Health Watch. Remember, you can watch previous edition of Health Watch online at www.norfolk.gov. If you'd like to drop me a line, you can email me at terrence.affer-anderson@vdh.virginia.gov. Please also feel free to give me a call at 757-683-8836. For the Norfolk Department of Public Health, I'm Terrence Affer-Anderson, and this has been Health Watch.